This is Dr. Stone-Gale. This lecture is going to be on tinnitus and Menieres disease. Tinnitus is basically a subjective perception of noise when in reality no environmental noise is present. And so what this does mean is that the patient may think that they hear noises that are not there. They could be intermittent noises, continuous, they could be pulsatile. So really they could be a sound that it would be synchronous to their heartbeat, but they're thinking it's another sound. Some of the risk factors include hearing loss as well as Menieres and otitis media. They could have a history of high or low blood pressure, hypothyroidism, hyperthyroidism, and even allergies. So they probably will hear a ringing, a buzzing, a roaring sensation in the ear, and that will be their main complaint. Many times their complaint is going to be that when all the lights are out, they're in their bed, there's not any sound at all, then they start hearing the ringing and the buzzing and the roaring in the ear. It's a very low-pitched sound. It can be accompanied by muffled hearing, and there is usually a change in the sound of one's voice. And this diagnosis is really very poorly understood. It's just very difficult for patients to understand why they have something that nobody can figure out why they have it, basically. There's many different ways that we can look at tinnitus. It's caused by, can be caused by impacted cerumen. It can be caused by having a tympanic membrane perforation or middle ear fluid. But there's many times they'll never find out what the cause is. And I think that's probably the most frustrating thing for patients. It can be classified in some different ways. So it can be classified as subjective, which is more common, and it's only heard by the patient. That's when they describe what they're hearing. The objective, which can be heard by you, the examiner, through a stethoscope placed over the head and neck structures near the ear. And then there's also a vibratory and non-vibratory. So with the vibratory tinnitus, it's usually caused by transmission to the cochlea of vibrations from adjacent tissues or organs, where the non-vibratory is produced by some type of nerve mechanism of hearing. Lab studies are done on these patients only to confirm if there's some underlying issue. So determining if there is a possibility of anemia or infection, so doing a CBC, also looking to see if there may be some type of thyroid disease going on, vitamin B12 deficiency, if they have high cholesterol, and then an MRI, usually for the diagnostic portion, an audiogram or an MRI. And the MRI is really the procedure of choice because it will give you the best results for what you're looking for. A referral is really essential when you suspect a conductive hearing loss or you do know definitely there's a conductive hearing loss. So how do we manage these patients? Well, elimination of the possible offending medication is really priority. So eliminating any aspirin or NSAIDs, these are the two medications that probably would be the most likely to cause any type of tinnitus. So it's a priority that those are eliminated. Unfortunately, tinnitus cannot be treated successfully, and this is what is very frustrating for many of these patients because there is no specific treatment, there is no specific way to eliminate it. You have to really try to encourage them to cope with it, and that's very difficult to tell someone you just need to deal with it. But this is what some of them have to be told. They may need to have oral antidepressants to reduce their symptoms because they do get depressed. So screening them also is important for depression. Protective hearing aids may work, or protective earplugs may work, and hearing aids are also helpful to suppress. They do help to amplify the environmental sounds, so it obscures the tinnitus. For patients who find the noise really intolerable, you can do biofeedback which may help some of their psychological issues. And then referring them to audiology should be initiated for patients with any type of hearing loss or tinnitus. And if they do have vertigo or they do have nausea or vomiting, you may need to have them see an otorhinolaryngologist. Next, we're going to look at Menieres disease. And Menieres disease is a peripheral sensory disorder of both the labyrinth, which is the semicircular canal system, and the cochlea of the inner ear. The endolymphatic volume and in turn pressure are increased due to some unknown etiology, but it does result in both the vestibular and auditory dysfunction. So the proprioceptive balance related section, as well as tinnitus, where they get the ringing or the buzzing in the ear, they get vertigo, which is that spinning sensation. They feel like they're whirling, and then progressive hearing loss. So although Menieres is not life-threatening, if it's untreated, acute attacks typically can reoccur over the years. And it is a paroxysmal attack. It lasts minutes to hours, and it does decrease in frequency. So unfortunately, the episode of Menieres disease lasts anywhere from 20 minutes to 3 hours, and it very rarely goes over 4 hours. But this rapid movement aggravates all of their proprioceptive symptomatology, and they often report a history of falls or accidents. When you do your physical exam on these patients, there really isn't any apparent abnormality that does show up. So how are we going to manage these patients? Well, one of the ways to manage these acute attacks is to treat, to give them bed rest with their eyes closed and protect them from falling. But pharmacotherapy, if necessary, is really directed at symptomatic relief because no medications are known to affect this nonspecific disease process. One of the first line therapies is to do a low salt diet, so 1 gram daily for 6 months to a year, and also giving them a mild diuretic such as either a chlorothiazide or a hydrochlorothiazide, acetazolamide, something like this, and giving them the potassium supplements if they need it to counter the diuretic-induced hypokalemia. Caffeine avoidance and tobacco cessation are also suggested so they won't have any vasoconstriction of the labyrinth system. And as with the salt restriction, the efficacy of these therapies really is based on anecdotal evidence. The acute attacks are managed with a combination of the antimuscarinics as well as the anticholinergics. So you may want to give them a transdermal scopolamine patch. Those are used when someone's going on a cruise for more motion sickness. There's also an option to give the Phenergan or Benadryl for the dizziness and Antivert. So there's a majority of things that you could give the patient. Some of them will work and some of them won't work. But the main thing to do is restrict their salt intake. If the symptoms don't worsen, then they can return for follow-up in 3 to 6 weeks. However, they should return for reevaluation immediately if their symptoms persist and they cannot resolve their symptoms. When would you want to refer them? Well, you would refer them to a specialist if necessary, if those symptoms worsened with the treatment that you gave. And then they may need to do some advanced diagnostic procedures to find out what's going on.